I'll start by welcoming everyone. I'm Sue Etkind from Eastman Cares, this is a continuation of our COVID-19 seminar series sponsored by the Education Subcommittee, which is Sally Wood and Dr. Ken Dolkart, and Paul, who's assisting, and Elise Kendall. So I thank them all for helping us set this up. And a couple things before we start, again, to make people aware that we do have an Eastman Cares Local Community Assistance Resource Guide, and it has just recently been updated, so you can get this either online or they have them done at South Cove. So please take advantage of that. The other thing that's new is the eCares Connection. And basically, if you know of anyone who needs to talk to someone or who would like to talk to someone for whatever reason, daily, weekly, monthly, whatever. But if you know someone who has that type of a need, if they could just email us at eastmancares@eastmannh.org, and we'll set you up with trying to maintain a connection. So we'd be happy to do that for anyone. Again, for a webinar format, there is no video for the participants. All you're going to see is the speaker and the slides. And briefly, Paul's going to handle the questions and answers. You also have no audio. However, you do have an opportunity, and we encourage you to do questions. You can put them in any time while the speaker is speaking, and you just go down to Q&A. It might be at the bottom or it might be at the top of your screen. And you put your question in there. Paul will be monitoring questions so that our speaker is going to stop periodically, and we will be sure that everyone's questions get answered. We'll have time at the end as well. And if we don't get all your questions answered, we'll figure out a way to get information back to you. But I think we'll be fine with that. We are recording this, and so we have, for those of you who have seen these in the past, they are being recorded and they are put up on the YouTube video format after the presentation is over, and I'll be sending those links out afterwards. I want to just briefly say our next speaker, which is actually next Friday, will be, excuse me, Ian Sim, Dr. Sim, who is going to talk to us about COVID-19 screening and testing, current and future, and what these tests tell us. So we look forward to hearing from him next week. He was another speaker along with both Paul and Dr. Sanders in a COVID-19 course that just finished up at Osher. So we'll look forward to that. I'm going to just introduce you, John. Pardon me while I read this, guys. John was born in downtown Detroit. His father was an OBGYN resident at Henry Ford Hospital, and he grew up on the west side of Cleveland. He attended Dartmouth, class of 1964. He left after 3 years to attend the University of Michigan Medical School, where he met his wife, Karen. I love this bio because there's some personal things in here too, which you often don't get. They moved to Boston for his training at Peter Bent Brigham Hospital in thoracic surgery. And then on completion, they moved to Chicago, where he did cardiac surgery at Northwestern Memorial Hospital and Medical School. They moved back to the Valley, the Upper Valley, in 1995, where he retired from Dartmouth in 2010. He continues, though, to teach at the Geisel School of Medicine at Dartmouth, and he's been active in the Good Neighbor Health Clinic. He's also past president of the Osher at Dartmouth. Wonderful, wonderful program. He and his wife, Karen, live in Lyme. I think that's his backdrop, is his tree. Use an evergreen tree, John, in the back of your porch, I think. They enjoy their nearby children and grandchildren, and hiking and skiing, and travel to Honduras yearly with ACTS, which is a local nonprofit, I don't know about this year, but a local nonprofit organization. So a man of many talents, and we are very happy to have him join us today. So on that note, welcome, John, and Paul and I will get ourselves off the screen here.
Thank you. Yeah, it's a great pleasure to be here. We actually did make it to Honduras in February, and we were the last group that was able to go when all of this struck. what I'd like to do is I will screen share and so that I can view my slides. And my slides have more textual information than I would normally put in slides, and that was because I intend to share them with you if anybody wants to have them. And so it's got just a little bit more than the usual amount of information. So I'm going to share. And that should work pretty well. And this is, just by way of background, this is an illness that is novel in that, to our knowledge, it did not exist in humans until very late last year. And so all of the information that we have about it has been uncovered and shared in the relatively short space of a year. And if you look at the progress, both of the knowledge that has been gained, but also the treatment and now the vaccines, that's an absolutely dramatic pace and bodes well, hopefully, for future worldwide infectious diseases that we will inevitably see. The disease is COVID-19. The 19 is because it was first recognized in 2019. And the virus is SARS-CoV-2. And the original SARS disease and the SARS virus, you might remember from several years ago, was it also began probably in China. It had an international spread, but although it was fairly deadly, it was not terribly infectious. And so the development of vaccines, both for it and for the Middle Eastern respiratory syndrome, MERS, which probably was transmitted from camels to humans, was an even more dangerous virus, but even less contagious. So the coronavirus family includes about 4 viruses that cause our common cold, but it also includes this virus, which has played havoc on a global basis. As to where it starts, there's an awful lot of misinformation and a number of conspiracy theories about it. But it most likely began in bats somewhere in southern China. And bats are known to be hosts to a variety of coronaviruses that do not affect humans. And this probably spread to an intermediate host. And the suspicion is that it was the pangolin, which is the spiny anteater. And that is both a delicacy in China, but also the scales of the spiny anteater are used as an aphrodisiac. And so it's brought to the wet markets in Wuhan, but also elsewhere in China. The wet markets are called wet because the floors are washed on an almost continuous basis, and large numbers of animals, poultry, swine, but all manner of exotic animals that are eaten in China are kept there live and then slaughtered for meat. And the thinking is that, as best we can tell, the first human infection was probably in mid-November of 2019. There could have been others, and that's always an issue as to know exactly when something like this begins. This is the pangolin, which is kind of a prehistoric-looking creature. It is a mammal. And as such, can harbor this particular coronavirus. It's thought that cats can harbor SARS-CoV-2 as well. There was a tiger in the Bronx Zoo that had it. Dogs, there is a report, which is plus minus, of a dog having contracted it, but that's not definite. When it began, the Chinese only reported a human-to-human transmission in January of 2020. That's a misprint. However, there were a number of physicians that were seeing a very serious, likely viral pneumonia in growing numbers in mid-December, and they were communicating this by social media. The Chinese government tamped down on this very quickly because of the concern about panic and about their reputation globally. And a Chinese ophthalmologist, Li Wenliang, who was only 34, was one of the reporting physicians. He was taken into government custody and later died of COVID-19. And so, the chain of information from China, at the very least, was quite clouded during that period of time. But on February 7th of 2020, Chinese researchers announced the entire genetic sequence of the virus. And that known sequence was shared globally and was the basis for beginning the work toward a vaccine, which we all know a bit about that now. The first cases that we heard about SARS were from Washington State in late January. However, it's highly likely that there were other cases about the same time in Los Angeles and very shortly after that in New York City. Europe and Iran were also reporting cases then. And the virus is what's called an RNA virus, in that, as you know, the nucleic acids that make up our chromosomes in our genes are DNA, which is a much more stable compound than RNA. And viruses can be based on either DNA or RNA, but RNA viruses are somewhat unstable genetically, and so they tend to undergo mutations frequently, and most of the mutations do not affect the contagiousness of the virus or the severity of illness, but it does allow you to genetically track their spread quite well. So, if you will, it's sort of a fingerprint. Now, there is some suspicion that that the SARS-CoV-2 virus may be mutating, and it may have actually made it more contagious. But so far, it has not made it more lethal, which did occur in the 1918 H1N1 influenza. The early cases of it were very severe, but the later upswing in cases in the fall were vastly more deadly. So symptoms, I mean, we all get asked these questions on an almost daily basis. And unfortunately, especially this time of year, it's very much like influenza. But there are some differences. The fever, which frequently has shaking chills with it, and a dry cough, as opposed to a productive cough, are found about 85 to as high as 99% of the time. Loss of the sense of smell or taste is also quite frequent and somewhat unique to this virus. And so that's something to pay attention to, if you're concerned. Shortness of breath is quite common, especially somewhat later into the course of the disease. And nasal congestion can occur, but a runny nose is not a very common symptom with this illness. The flu-like symptoms of fatigue, muscle aches, headache, nausea, vomiting, diarrhea can also occur. And one of the really disconcerting parts of this is that about 40% of people who actually have the illness do not have symptoms, and so remain contagious, which is a very serious problem. And unlike a number of other illnesses where symptoms occur sometimes even before fever, and you can have people isolate, that's not true with this virus, and it has been a major problem. As far as how it is spread, a fair amount is known about that now. Respiratory droplets, which probably account for the majority of transmission, and they are dramatically reduced by masks. And singing, coughing, shouting, and sneezing greatly increase the production of droplets with those activities. Aerosol transmission is different. Aerosol transmission is microscopic droplets, and they can remain suspended in the air for sometimes hours. And it's one of the reasons why, even wearing masks but in an enclosed, poorly ventilated space, you can get human-to-human transmission very easily. And it's one of the reasons why churches have tried going back to worship in person, being spaced several pews apart and fairly widely, and they still have seen major outbreaks, and a lot of that is this aerosol transmission, which can kind of hang in the air, and a number of schools and businesses have dramatically changed their ventilation systems so that they allow outside air exchange and limit the amount of exchange between different rooms. And from a heating, ventilation, and air conditioning standpoint, that's a very difficult thing to retrofit. Some places have been able to do it, but a lot just simply cannot. You can detect viral genetic material on surfaces, but the good news is they probably don't remain a source of infection for more than a few hours. And this is probably a relatively poor means of transmission. Food and food preparation and stuff does not seem to play any detectable role in this, which is good. And yet the cruise ships that were so devastatingly affected, they were able to pick up the genetic material weeks after the ships had been vacated. Incubation time, which is the time between exposure and symptoms, is anywhere from 1 day to 12 days. So it's kind of all over the map. It's one of the disconcerting things is that you can be infectious before you're symptomatic, which also plays a very serious role. All ages can contract it, but infants and children under the age of 12 really don't have much in the way of symptoms in general. There are some children who've died of it, but they almost all have some form of pre-existing condition that makes them more susceptible. And there are a couple thoughts about why that might be. Children have a very robust, what's called innate immunity, which is immunity that allows them to fend off viral and bacterial infections without a specific antibody response. And they certainly develop the antibody response, but their innate system is more robust than older people. The other thing is that the little spikes on the coronavirus latch on to what are called the ACE2 receptors in the human body. And that's the angiotensin converting enzyme, which is blocked by a number of drugs that we take for hypertension. And there are several different classes. But adults have a much more robust expression of the ACE2 receptors on their cells than children do. And so that may in part explain why kids develop it. Kids also appear to be less contagious, that is, in terms of spreading it to other kids and to adults. And that changes about age 12. And between 12 and 19, teenagers are fully capable of developing the disease, and they are every bit as contagious as older adults, but as many as 80% have no symptoms, which makes keeping tabs on groups of teenagers in terms of preventing transmission a real difficult problem. Symptoms tend to increase with age, but even the very elderly can be asymptomatic. As far as how contagious it is, and I think I'll stop after this slide and see if there are any questions before we go further. The epidemiologists talk about the R0 number or the RT number. And what it means is how many people can contract the disease from a single infected person. So the higher the R number, the more contagious the disease is. And an R number less than 1 is ideal. Measles has an R number of between 12 and 18, making it one of the most contagious infectious diseases known. And the part of the problem with that is that when you're looking at immunity and what it takes to achieve what's called herd immunity, that means with measles, it's got to be over 95%. So even a handful of people that aren't vaccinated are a problem. And infants are not vaccinated until they reach 1 year of age. So they are very vulnerable to this, as are older people who've not been vaccinated. SARS-CoV-2 probably has an R number of between 2 and 4, but it fluctuates a lot. Germany has achieved an R value of about of less than 1, which is remarkable, and that's without vaccination or any specific pharmaceutical treatment. And the R value is altered by a lot of factors. It's dramatically reduced by vaccines, so there is hope that we can begin to achieve some protection very soon. Different countries have different R numbers, and a lot of that is because of different governmental response to an infection. Universal masks and social distancing alone probably can bring the R number down to 1 or less, and which is why it's going to be so important to continue universal masks and social distancing going forward until the vaccine has reached a large part of the population. So Paul, I'm going to just pause and see if there have been any questions.
There have not been any questions in the Q&A, but I thought maybe I would ask you a question.
Sure.
Relating to the children and the relative absence of symptoms in the children. It has been offered as a reason to continue having in-person schooling. Is there a downside to that proposal or that policy?
I think the biggest problem with that will be the teachers who are older, and of course, older caregivers at home, both parents and often grandparents that are participating in at-home care of kids are vulnerable. And even though kids are thought to be somewhat less contagious, they can still spread it. So it's I think most people would agree that unless an outbreak is very severe, that probably children under 12 should be okay to continue with school, assuming and especially if teachers can be vaccinated.
Okay. All right, still no questions. I'll ask one more, and if nothing since has come in, then we can continue. But we all know that flu has a tremendous genetic plasticity, if you will. It can change frequently, and most folks, I hope, are now familiar with the terms drift and shift, small changes or a major change. We know that there have been multiple strains of the SARS-CoV-2, and we expect this to be a parallel kind of a situation with influenza, with changing strains of CoV-2, or perhaps not.
Well, I think I mean the biggest worry I think with COVID-2 is that it's still early days. I mean, we're less than a year into it. Really, only, for the most part, 10 months or so in the U.S. And it is an RNA virus that can mutate fairly significantly. So it's not at all impossible that we would see either a decrease in contagiousness or a decrease in how lethal it is, but that could go the other way as well. And one of the big concerns has been, what does this mean for vaccination? Because we're clearly, we're using the strain of the virus that was sequenced very early. Will that affect the ability of vaccines to work? And it's very early days to know that.
Thank you. There's no other questions right now, so
I'm going to
continue.
I'll continue, so the this is kind of a busy graph, and what I'm going to try to point out is the blue curve is how much circulating virus a person has in their body. And obviously, somehow we get infected on this axis. These two lines look at tests, and the PCR, or polymerase chain reaction test, is the gold standard at the moment. It's been used in one form or another since the beginning. It's a fairly complex test that takes a number of hours to give a result, but it's also very, very sensitive. There are a large number, actually, of low analytic sensitivity tests coming along. These include ones that use saliva, so could very possibly be used at home. And the result verified perhaps with some form of an app on a telephone, and the Abbott Labs card-based test is one of those, although it still requires a prescription, and is not. It's becoming more widely used, but it's not in far wide use yet. But a highly sensitive test is going to detect the virus, ideally, at least a short distance before the patient becomes infectious, which means their viral load has increased. And the one of the downsides of the PCR test, though, is that you stop becoming infectious, assuming you've handled the disease well, somewhere around 10 days into the course of the illness. But the PCR test is going to stay positive for quite a long period of time, maybe as much as a week or more after you're no longer infectious. So if you're basing ability to go back to work or school on a positive PCR test, you may be limiting people for a much longer period of time than you need to. Now, the lower sensitivity tests, though, probably will pick up infection as people become contagious, which is this infectious period in the bright yellow. And it's likely that when the low analytic sensitivity tests become negative, that even though you may still have some circulating virus or viral remnant, you probably have lost your infectiousness. And this is the hope. And I know you're going to have some talks coming up about the various tests, so I'm not going to spend a lot of time on them, except to say that my personal belief is that an inexpensive at-home or say, as you go to work, as you go to school, as you go to a restaurant or a theater, a test that would give a report within minutes and basically allow us to only admit people who are not contagious would be a dramatic change before we reach herd immunity or complete vaccination. And I think those tests, I'm looking for them literally almost any week now. I think by the first month of this coming year, those tests will be widely available, and that'll make a big difference. So in terms of how serious is it, we're learning more about this disease on an almost daily basis. Initially the mortality rate was as high as 5.5% in what I would call relatively young people between 50 and 59. It's down out of 1.7, and a lot of that is knowing more about how to treat it, knowing who's at risk, who's not at risk. One of the nice things is that children under 12 rarely get serious disease. And the children who do get serious disease tend to have existing conditions, diabetes, cancer, immune problems that predispose them to get serious disease. It is known that the mortality greatly increases with age. As many as 19% of people who contract the disease may require hospitalization. And of those who are hospitalized, as many as 20% may die. So if it were not as contagious as it is, it would probably not get the attention that it has. But because it's so easy to have large numbers of people infected, even a relatively low percentage of serious disease becomes a major health problem, as it is right now in the US. If you actually have to go on a ventilator to get enough oxygen into the system, the mortality was as high as 80%. That is dropping. And the number of people who require a ventilator has also gone down dramatically with some of the possible treatment options, but also just knowing more about how to manage these folks. one of the sobering things is that patients who have a cardiac arrest and require CPR, who have COVID-19, so far there have been no survivors. And it probably relates to the fact that people who have a cardiac arrest have such severe lung involvement that if you can't keep them alive, you're not going to be able to resuscitate them after they have a cardiac arrest. Progression of the disease is fluky. Most people recover in 10 or 12 days. And, fortunately, 81% or so have what would be called mild to moderate disease. Mild generally means little or no in the way of respiratory symptoms, so no shortness of breath. Moderate usually has some respiratory symptoms in terms of shortness of breath, but it isn't progressive. Severe disease, which is not only shortness of breath, but a drop in the amount of oxygen you can take in through your lungs. And these people show severe lung involvement, and that probably is as many as 14% of people who develop COVID. And critical is beyond the respiratory failure. These people develop multiple organ failure, kidney, heart, brain, liver. So it's a multi-organ problem. And it's a very small number of patients. There are some children, infants and children who have developed this, usually with pre-existing conditions, and it has a very high mortality. In addition to the severe lung involvement, we're also seeing multiple vessel, both arteries and veins, clotting. So not just phlebitis, but stroke from literally clotting of the carotid arteries, and beyond the large and small vessel clotting, there's something called the cytokine storm, which is basically a systemic inflammatory thing that once it gets going, tends to be sort of self-sustaining. And if you actually look at the viral load of patients like that, it's not as many as you would think. And I'm seeing, Paul, a couple questions and would be happy to answer.
Sure. So the first one, taking them in order, from Jane or perhaps Richard Sachs. How can you identify that someone is not infectious when the PCR test is positive?
So the only way you could actually do that, and it's a very difficult task, is to culture the virus. And there have been some studies that have used viral culture. It's problematic because it's a much more complex undertaking. And the real problem is that most of our testing right now is the PCR based. Some of the rapid tests, which are often antibody based, in other words, the testing kit has an antibody in it and an indicator, so that if it identifies a COVID particle, it will change color in some way, and those look like they may be enough less sensitive on the post-infectious end to be to perhaps be more useful in terms of identifying folks who are no longer infectious.
Okay. We have from Kendall Cart, there are immunocompromised folks who might be unable to effectively clear a virus. Is there a tool other than PCR to assess genuine infectivity of such patients?
That's a very good question, and I'm not aware of a good tool to do that. There are some treatments which we'll talk about that might be very helpful for that group of people. And normally the disease would run its course in a fairly short period of time, perhaps as little as 10 days. But in somebody who is immunocompromised but doesn't get severe disease, it's not really known how to know when they're no longer infectious. The usual time frame has been pegged at 10 days, and I'm sure that there are some that are infectious beyond that, but it's a shorter period of time than was initially thought. Initially, you were to quarantine for at least 2 weeks.
So as a follow-up to this, is there a role for viral load or PCR for quote unquote live active virus in selected cases?
The viral load is harder to determine. There may come some tests that are good, are able to do that. And then actually the PCR test can do it indirectly. And because it's a chain reaction, it takes multiple different incubations, if you will, and how many cycles it has to go through to give you a positive PCR test is kind of it's inversely related to viral load. So if it only takes a couple of cycles of the PCR to get a positive test, that means the viral load is pretty high. And consequently, if it takes many passes to get a positive PCR, the viral load is probably very low. And I don't actually know how many cycles are normally run for a diagnostic test. I think it's on the order of 30, but I could be wrong.
And the last question we have currently is from Duncan Wood. Any idea how expensive the at-home testing kits may be?
Well, I've heard that the goal is tests that will cost between $1 and $5. So a relatively low cost. And of course, one of the benefits of rapid at-home testing would be that you could repeat it, several times a week, or, before you went to church on Sunday, or before you went out to a restaurant, and maybe in case of the Abbott test, which is interesting, they actually have an app developed for it. So you take a picture of the little card that'll display either a positive or a negative test. And so now you've got the date and time of the negative test, and maybe you could use that as your entrance into a restaurant or theater, school, work, what have you. And that if something like that truly becomes an at-home, inexpensive test, that will go a huge distance toward reopening our economy and our businesses and everything else.
Okay, those are all the questions that we have currently.
Well, let me continue. COVID has some quirks that we don't see in other viral pneumonias. And one of them has been called happy hypoxia. You normally feel short of breath when the carbon dioxide level in the blood begins to rise. And there's a tiny region in the brainstem that is exquisitely sensitive to this. And it's what controls your respiratory rate, both at rest and exercise. And if there's too much carbon dioxide on board, you feel short of breath. one of the problems with COVID is that people can stay relatively comfortable, which means that they're getting rid of their carbon dioxide all right. But they can stay comfortable even though their blood oxygen levels are falling fairly precipitously. And the terrible part of that is they can go from feeling relatively comfortable to deathly ill in hours. And so one of the things that has been proposed and is being done in many places is the little gadget that is put on your finger when you go to many doctors' offices or in the operating room or many other settings to measure your oxygen saturation by optically through the skin. Is a very good indicator of how well oxygenated you are. And so as part of having people stay at home with COVID, issuing a little pulse oximeter, which is quite tiny and easy to use, so that they can carefully monitor their oxygen level. And if it begins to fall, get into the hospital is a reasonable strategy. But feeling the shortness of breath with COVID, especially at rest, is a fairly ominous sign of transition between mild to more serious illness. And it right now is one of the major indications for hospitalization. So this is one of these bizarre parts of the disease that is not seen in other illnesses by and large. One of the things that's been very clear is that Hispanics, Blacks, and Native Americans make up a disproportionate number of both cases and deaths. Overall, 45% of all deaths are of Hispanics, and as many as 29% are African American. And of the childhood deaths, which definitely do occur, 75% are Hispanic, Black, or Native American. So there's an enormous racial disparity with this illness. And there have been lots of questions as to why that would be true. Some of it may be because living conditions are more crowded. Many of that population are what we would call essential workers that are going to have more frequent contact with the overall population, but also they have less access to routine medical care and more pre-existing conditions. The incidence of diabetes, type 2 diabetes, is much higher in African Americans and Native Americans. So how much is pre-existing conditions, how much of it is lack of care is concerning. And there's been a lot written about it, and I think we're going to hear a lot more about it as we go forward. Most of the severe disease is in patients who do have pre-existing conditions. And some of them are pretty obvious: obesity, diabetes, hypertension, heart disease, chronic obstructive pulmonary disease, which is emphysema. But interestingly, asthma is not so much of a pre-existing condition for severe COVID. And it's counterintuitive. It's not clear whether the medicines and inhalers that are used for asthma may be favorable in terms of preventing severe disease, or whether the pathology in the lungs themselves is not sufficient to cause more susceptibility. Interestingly, some people are less vulnerable than others. Women seem to be less vulnerable in terms of mortality than men. People with type O blood group generally fare better, and otherwise healthy children do very well. People who are taking statin drugs for high cholesterol also seem to have some protection against the severe form of the disease. And that's observational. And I'm sure there are some ongoing trials now to look at the association with statin drugs and better outcome is real or perhaps just an observation. And that's one of the issues with a disease that's as pervasive as this one is. When you see an observation like the statin drugs maybe reducing it, it's really hard to then turn around and do a randomized prospective double-blind trial, which is the scientific gold standard to verify whether or not that observation has merit. Immunity, huge unknown right now, and most recovered people after COVID do have a robust antibody response. What's not known is how long that lasts, and that's an issue. And it's also not known whether those antibodies protect against reinfection. It is known that even when if durable antibodies are not present, the immune T cells, which are the memory bank of the immune system, may persist a lot longer and enable a rapid reproduction of antibodies if infection threatens to occur. And all of this greatly affects the implications of a vaccine. If you've got to have a vaccination every 6 months or so, it's probably not going to be very helpful. If it can last even a year or more, then making it somewhat like the annual flu shot becomes a real possibility. Herd immunity, which infamously was touted as how we should go about doing this, really depends upon large numbers of a population being immune. And this has almost always been done with vaccination. And one of the issues is that the higher the R number, the higher percentage of the population has to be immune to achieve herd immunity. And if you rely on natural infection, unfortunately, you're going to lose through death a large number of people to achieve it. Sweden initially started with that idea that they would allow the herd immunity to take place. They would try to keep people that they knew of higher risk, older folks and people with pre-existing conditions, kind of sheltered away, but they wouldn't close schools, restaurants, bars, and this sort of thing. And nor were they using, widespread mask wearing. Well, it looked pretty good initially, but in comparison with their Scandinavian neighbors, they had many times the incidence of cases later on. They also had a much higher mortality rate, and the impact on their economy was far worse than neighboring Scandinavian countries. So it's not a practical approach. And this appeared in a newsletter from someone, and herd mentality is a play on words, but it's the amount of misinformation on this and conspiracy theories on this illness are just astounding. And they tend to abound when people are science deniers, and they tend to abound when you're dealing with something that doesn't have a simple answer. And in this case, COVID is a perfect example. So masks unequivocally reduce transmission. The protection is greatest for the other person, but there probably is, if both people are wearing masks, there probably is protection for the wearer as well. And one of the things that has been proposed is that wearing a mask may reduce the actual intensity of exposure to the virus. It just means the number of viral particles that you're able to inhale is far less than it would be without a mask. And in the smallpox era, prior to Jenner's discovery of the cowpox virus, the vaccinia virus, variolation was used for smallpox. And what that meant is you took just a little bit of one of the smallpox lesions and scraped it onto the arm of somebody who had not had smallpox. The idea being that they would get a very mild form of smallpox and become immune to it. And variola is the name of the smallpox virus. So it's not clear whether this is taking place or not, but there have been a couple of studies looking at incidence of disease and deaths in adjacent counties in some of the states that have been particularly hard hit. And in many of those states, it's a county by county decision as to whether you must wear a mask or not. And not surprisingly, the mask wearing counties had a vastly reduced incidence both of the disease and of death from the disease. So there's absolutely no question now that masks are critical. Treatment, this is a slide I had to very carefully look at because it is changing on an almost weekly basis. There are some things like hydroxychloroquine and azithromycin that were touted by a kind of a renegade French physician who put it out on tweet that he'd had great success with them. There have now been prospective randomized trials with both of these drugs in combination, and they are not only not helpful, they have a fairly high harm profile. Hydroxychloroquine in some people causes severe heart arrhythmias, and so it's not useful for either preventing the disease or treating it. And azithromycin in combination with it has also been disproven. Pooled convalescent plasma was used in 1918 for influenza. It had some effect. It was used for Ebola with some success. It has not shown in the prospective randomized trials, it is not shown to be significantly helpful for COVID-19. Remdesivir, which is an antiviral, has shown some benefit for hospitalized patients. It has to be given intravenously, and it's certainly not a cure-all. The monoclonal antibody cocktails have looked quite promising in trials, and I think have now gotten emergency use authorization from the FDA. Monoclonal antibodies are basically usually mouse cells that have been humanized by human DNA and are able to produce human antibodies that are very specific. And so these monoclonal antibody preparations have basically specific antibodies against certain specific parts of the viral particle. And they look very promising in people who would normally be hospitalized, but are fairly early in the course of the disease. Now, remember that early in the course of the disease, the virus is the most active at causing the illness. Later in the course of the disease, the body's response to the virus may be part of the problem. There are several phases here. Decadron, which is an old drug, it's quite literally hydrocortisone on steroids. It's roughly 10 times as powerful as hydrocortisone, and it's given intravenously. And it looks very promising for moderate to severe cases. It has shown harm in mild cases, so it isn't something that you take right off the bat. Statins, we talked a little bit about. Proning, which has been around for a long, long time. People with respiratory failure, if you can use a special bed so that they can lie face down, they often can ventilate and exchange gas much more readily than if they're on their back. And so so-called proning, which is, as you can imagine, if you've got a person that weighs 400 pounds, what kind of horsepower in terms of nursing and nursing assistance it takes to turn them face down. I mean, it's a very serious problem. But it has shown the ability to keep a number of people off of ventilation or off of a ventilator, so that a vastly fewer number of people are requiring that kind of assistance. And as far as other drugs are concerned, there are some other drugs coming along that look like they may be helpful. Some of the antacids, interestingly enough, may play a useful role. I'm going to mention ECMO, which was developed in large part by a man that I was a resident with in Boston, and it's extracorporeal membrane oxygenation. And the idea is that you have a little machine that's a handle, so it's quite carryable. It's got this tiny module, which is a full-blown oxygenator that can quite efficiently do what both lungs do. And as part of this, there is a little tiny centrifugal pump that basically pushes the blood through the oxygenator. And there are some other elements. You've got to have a heat exchanger so that you don't make the person way too cold. And it can be used two ways. You can connect this, the blood has to leave a vein and go to the oxygenator, but then you could pump it back into an artery if the heart were failing, or if the problem is strictly the lungs, you can actually pump this oxygenated blood back into the superior vena cava right near the heart. And so now the blood that's going through the lungs is already oxygenated. The lungs don't have to work. This can, a person can actually walk around with this device functioning with a lot of support. It's difficult, but it can be done. It avoids the need to put a breathing tube down through the throat and into the windpipe. And it basically allows the lungs to completely rest while they are recovering. And this has been used successfully both at DHMC, but also internationally. It has terrific value for victims of freshwater drowning, which damage the lungs in a fashion that they could recover from. It has terrific value in some of the very sick young people with H1N1 flu when it made its reprise. I want to say 2009, but I might not have that date right. Young people could be put on ECMO for a week or two and make a complete recovery from what would otherwise be an absolutely fatal illness. And it is showing some use in adults for COVID. Now, long-term sequelae, long-term, the longest recovered person is only about 8 months or 9 months behind us. So there's not a lot known, but one of the concerns is that some people who have apparently recovered can have lasting problems, including kidney, brain, liver, and even heart damage. There was an interesting study of OSU athletes who had mild symptoms. They did cardiac MRIs, and all 17% showed some evidence of inflammation of the heart and definite damage. So this is in people without significant symptoms. There are a number of people who are now reporting persistent symptoms after recovery, and there are a number of people now who have reported a second infection. It looks as though the viral genetics are different in cases where there's a recurrent infection and where it's been looked at. Thankfully, most of the second infections have been relatively mild. And finally, vaccines. There are 110 vaccines roughly in development worldwide in various phases of testing. Pfizer and Moderna, I think we're going to see being given to people in the United States, I would bet in the next week. It's a nanoparticle lipid that encases the viral RNA fragment that's responsible for producing the protein that's on the spikes. It does require 2 doses, and the cold chain, which is the temperature at which you must manufacture, transport, right up to the admission time, and verify that cold chain at every step of that process, is -90 Fahrenheit for the Pfizer. It's -4 for the Moderna, even though they're very similar. It's a different lipid nanoparticle. The AstraZeneca vaccine, which everybody has heard about, I think, it uses RNA that's linked to a modified chimpanzee adenovirus, and it requires 2 doses, but it has a reasonable cold chain. It had some funny business in its early trials. A group inadvertently got half a dose for their first injection, and that group actually had a better subsequent response than the group that got a full dose. So there are some unusual things about that. The Russians pretty much raced their Sputnik 5 vaccine out. It's RNA linked to 2 different modified human adenoviruses, and it's got a reasonable cold chain, but it requires 2 doses, and each of those vaccines has a different vector, a different viral vector for the RNA. J&J Sinovac is an inactivated SARS-CoV-2 virus. 40 degrees Fahrenheit is sufficient to preserve it, and it requires 2 doses. But again, they kind of skipped phase 2 and phase 3. They just went pretty directly to human use. J&J uses a modified human adenovirus vector. It looks like it has both a reasonable cold chain, so refrigerator temp, and a single dose like a flu shot, which would be a huge step forward, especially for parts of the world that don't have the ability to maintain these intense cold degrees. And I believe that is the end of the talk, but I'm happy to take any questions. And if there are questions beyond this, I will send my my slide set to Sue. So if others wish to take a closer look at it, and I'm happy to answer questions.
So we have none right now in the Q&A or in the chat. So if you have a question, please do. Okay, we have one. So I think this is Barbara Johnson. What makes the difference between needing 1 and 2 doses for a vaccine?
It has to do with how robust the antibody response is. And the in actuality, the Pfizer vaccine has a pretty good initial response, but the number of people protected was only about 60% in the phase 2 trials. And you get up to 95% with a second dose. The J&J data is not in yet. They are not through phase 3 yet. So we're going to know a whole lot more, but they are suggesting, at least in the early data, that a single dose will give an adequate response. And that would be I mean, it's like any drug. If you've got to take it more than once a day, the chances of compliance get a whole lot worse.
Okay, and can you talk a little bit more about help for long haulers? Barbara Jones, not Johnson, I'm sorry.
So the long haulers, there's so little known about what makes it long haul. And some of this is small vessel clotting in critical areas. Can be brain, can be kidneys, can be heart. And what's not known is that an injury that will completely heal and go back to normal, or is this going to represent literally a permanent disability? Unfortunately, the body's pretty good at building up muscle and other tissue around an injury, but the extent of the intravascular clotting that's been seen in the in autopsies has been absolutely striking, and it probably doesn't occur in the mild forms of the disease. Fortunately, it tends to only occur in some of the people with the severe form. But I would be willing to bet that some of the long haul issues are related to small vessel clotting that we really can't detect.
Is there any evidence that the long haulers continue to be infectious for such an extended time?
They probably are not. The severe forms of the disease, if you actually do viral cultures on people with the severe lung involvement, the cytokine storm, the intravascular clotting and stuff, their viral loads have fallen way down by then. But it's the inflammatory response that the body puts forward to fight the virus that becomes part of the problem. And that was true with H1N1 too.
Thank you. Sue, do you want to take over?
So I want to thank you, Dr. Sanders. That was an excellent presentation, and we really appreciate you taking the time to share with us. As I said, Dr. Sanders' talk will be provided via a YouTube link in the next few days, so that if you would like to see it again, or if you know someone who did not have a chance to see it, by all means, I would highly recommend them looking at it. He also said he would provide us with slides, so if you are interested in that, by all means, just again, send me an email, eastmancares@eastmannh.org, and I will be happy to do that. And I look forward to seeing everybody next week when we have Ian Sim, who is a microbiologist. We'll get into more specifics about screening and testing. And thank you all for attending. Thank you. And at that point, thank you, Dr. Sanders.
Thank you, Dr.
What a
Sanders.
pleasure, and have a wonderful holiday.
Everybody
Thank
have a
you.
wonderful holiday. Stay safe and stay well. Night.
Bye-bye.
Take care.